I hope to present 3 cases. They are simple. I hope, I'm not really sure. I do not have any financial disclosure for this presentation. Case 1 is a 4-year-old boy who is premature. His birth weight was 1.4 kgs. No ROP screening was done. He had a history of respiratory distress. And elsewhere he was given glasses as well as advised patching. He was not wearing them. There was poor compliance with that. And he was a patient of very attention deficit hyperactive disorder. And his visual acuity was 2200 in the right eye and 2400 in the left eye with eccentric fixation. His refractive error was -4 diopters in the right eye and -1.5 diopters in the left eye.
Just 1 second, Ramesh. Yes. Go back one slide.
Yes.
Now, how many of you asked for history of prematurity in a child which walks into the field? Excellent. All of you should know that. Number 2, how many of you asked specifically, was the child in an incubator for more than 7 days? No, look at my question. Ask the parent that was the child in the incubator for more than 7 days. How many asked? See that it has come down. So you must specifically ask. 3 days is okay. Many children are in the incubator for 3 days, or even jaundice, they put them in the incubator. Like specific questions asked. More than 7 days, were they in the incubator? That's important to ask rather than were they in the incubator? Yes, everybody says initially I did that. Because I analyzed my result. 90% they were in the incubator. So then I realized you have to change the question. How many of the children were in the incubator for over 7 days? Then that comes. Okay, the specific question you ask will be 7 days, not just in the incubator. Yes,
Significant finding was dragging of disc with dioptric changes and pallor and straightening of vessels in both eyes. So definitely says that it's a case of probably a regressed retinopathy of prematurity. And rest of that retina was attached. So this is his finding. He had an anisotropy of 25 different diopters with left eye associated vertical deviation. We could not elicit in the right eye in spite of using Spielman or Kruger because he had a kind of eccentric fixation. This is very important. And on measurement, the question here is what is the kind of measurements you use in this kind of situation? Do you do a cover test or a modified Krimsky test and how do you measure?
okay, just let's go back to your slide 2. This one. Now if you look at that, his refractive area is -4 in the right eye, -1.5 in the left eye. Normally with this abnormal refractive error or asymmetric refractive error you have, you would more likely see a DVD in the eye with higher refractive error than in the eye with lower refractive error. Because the eye with lower refractive error will usually be the fixating eye. And the one with higher refractive error will be usually the non-fixating eye. But here, it's very funny. The non-fixating eye has a lesser refractive error than the fixating eye. That you have to remember. Second, yes.
Yes, the straightening was and the dioptric changes were a little bit more on the left side compared to the right side.
Okay, the second point you have to ask yourself, when you see a dissociated vertical deviation, okay, usually the dissociated vertical deviation is a bilateral condition even if it is asymmetric. Okay, usually it is 95% of the time it is bilateral, rarely you see unilateral. Number 2, a DVD manifests when there is an obstacle to the vision and fusion in the early months of life. That is, in the first 4 months of life, there is an obstacle to fusion. DVD suddenly develops, although it may come at a later. These are the 2 points you have to remember. Now, if you look at this patient, fundus shows disc dragging. Okay, just go back. The fundus shows disc dragging, rapid changes, pallor, and straightening of the vessels in both ways. Now, what would it give a clue? You have prematurity, you have disc dragging, what should it tell you? That is probably a neglected or not diagnosed or not looked for in my experience in ROP, you find 40 to 50% of the children tend to have myopic astigmatism. I don't know why, what is in your experience?
Not really myopic astigmatism. We have seen more of a myopia. That too, mostly lenticular. It's not axial.
Okay. What is your?
We see myopia. I'm not sure whether it's purely like I don't.
Yeah, most of the time it's not axial. Somehow.
Big study in Chicago shows that it's lenticular.
Right. Right.
It's non-progressive. Really, I would say that the myopia is not
More corneal than
well, we don't investigate very often because it's not possible to go into the details. But my impression is myopic astigmatism or myopia in ROP does not usually progress. It is not very high. It is usually around 3, 4, 5, around that, not much. And the astigmatism is around 1 to maximum. It doesn't progress, it remains constant. So that is important to remember. So now, you have any fundus pictures of the peripheral?
Unfortunately not.
Is it an eccentric fixation? I mean, or is it basically a macular drag? I mean, somehow I don't like this drag. It's better to call a drag macula. In cases of ROP, which is causing a shift ectopic macula, which causes a eccentric viewing situation. So, is it an eccentric fixation?
It's definitely because of the dragging of the fovea.
So, it's not an eccentric fixation.
Yes, it's eccentric viewing because of ectopic.
I'll tell you this is I remember very clearly a patient with ROP with all these problems. The child initially came with what looked like exotropia, but the child actually had esotropia. The child actually had esotropia, but to the parents, the child looked like had exotropia. I told them if I operate, it will only worsen. But the child needs surgery because there is certain degree of amblyopia. So I operated and of course I was not surprised the exotropia increased. So it's important to remember in ectopic macula, your squint surgery should be carefully tailored than when you do that. May not be done.
It is pseudo.
Yes. So you may ignore. Yes. You need a mic.
And probably it's a good idea not to use any of the corneal reflex tests for making your surgical plans. If you do see ectopic macula.
Sure. Okay. Go on.
The question is, what test do you use here? This is the presentation without any occlusion. This is where we had a left head till tube, but when we make the face straight, this is what is this presentation. So which test do you use in this kind of situation?
Do you have 9 positions?
Yes, I do. I don't have 9 positions. He is kind of little bit naughty guy, so could not get 2 positions.
What happens when you cover the right eye? What happens to the left eye?
Left eye takes up different fixation. It's still esotropia, but less esotropia than this. Hypertropia also is same. Same.
Eso is less than the
Hyper is the same.
Hyper is the same.
Yes.
And he maintains that vision that he has. That
He has 2400. Yeah.
with that.
Right.
If you go to your 6 positions, you have. Now here, when you look at it, it could be just a DVD, or it could be inferior oblique overaction, or it could be both. Correct? Now, in the presence of DVD plus inferior oblique overaction, in adduction, the way I differentiate whether probably it is the DVD component which is pulling the eye up, or it is the inferior oblique component, what I do is when you lift the cover, you realize that the DVD component of the refixation movement is a slow downward movement, whereas the inferior oblique refixation is a fast. Am I right in saying that? So that's how I take into consideration whether it's an inferior oblique or it's a
defect and there are no superior oblique on the left side. Minus 3.
In fact, the superior rectus should be tight now because of the long standing. Because the vision abduction, you might see that.
You can see in all the directions the hypertrophy is more in adducted, primary and abducted position. All the places it's there. We did force traction test as well as FTT just before surgery.
Yes.
Very, very lax superior oblique. Superior rectus was not tight and other muscles were not tight. Even the medial rectus on the left side was not tight.
Was there any elevation in the right or is it just that?
It's just an apparent.
There's no elevation.
Yes.
Okay, you must notice what Ramesh mentioned. We did the test on the table, he said. Now that's very important. Any squint you operate, even normal squint or even functional squint or a cosmetic squint, please do the post-action test in all directions on the table. You don't lose anything except 1 minute. But the information you gain may be very useful and very helpful. How many of you operate on squints here? All of you, very good. Excellent. This is a biased question. Next, how many of you have, or how many of you always do FTT on the table in any type of squint? There you go, the number comes down. How many of you have tackled all the available extraocular muscles in the management of squint? There you go. So therefore, the question you ask should be such that the response will be more and more specific. So you want to know about it, there is one research question framing in IGO talk tomorrow, please attend that also. Okay, you go on next.
Yeah, I just wanted the opinion of the panel. How do you do surgical procedure? I will show what I have done.
Okay. Okay, let's start. Rohit, what would you do?
I would probably, suppose he says lax superior oblique, so I would do a large, actually inferior oblique and probably the superior rectus also. So this is what I would say speaks lateral superior rectus.
the mic, please. Okay, Rohit says he will tackle the.
I'll come to all of you, please give Rohit this answer. So Rohit says inferior oblique, superior rectus. You, Smita? Huh? Okay, fine, fair enough. You will try and patch and give the contact lenses for the eye and see. Okay, fine. Okay, then.
Yes, inferior oblique and just superior rectus.
I would like to do, since what is the esotropy and primary position?
Approximately 25 is the
Excellent. I would do a medial rectus recession alone, which will give in my hand one muscle correction alone will give me about 15 to 18 prisms of correction. Since there is still 7 prisms left, I would do a coordination of medial rectus with recession of the medial rectus plus anterior position of inferior oblique, which will take care of DVD and it will take care of inferior oblique overaction. And since there is no superior oblique overaction there, it is perfectly alright. So I will do medial rectus, coordination, recession and inferior oblique anterior position. What would you do, Pradeep?
I would like to first see what happens when you cover the right eye. Is it a true deviation or there is an apparent deviation effect because of the ectopic macula? Because that has to be taken into account. That is one thing I would take a consideration of. And the second thing, as he said about the post-action test, I would do a medial rectus recession. I would do a total anterior positioning with maybe a +2 station that Dr. Eisenberg got me to do to add to the effect of anti-elevation to help that. And if required, tuck the superior oblique, but I would not like to touch the superior rectus because the ability you said was free for superior rectus.
Right? The rectus is free.
So I wouldn't recess the superior rectus. If at all I require for the more hypertrophy, I would then add the superior oblique tuck to press.
Thank you, Pradeep, for agreeing with my management. I forgot about ectopic macula, but does in these cases, my feeling is the left eye will off, right eye will go up after you have done the anterior position, opting to the left, because you have to be extremely careful to rule out the absence of DVD in the other. Invariably, there will be some amount of DVD because the vision has been affected very early in life, so it's a central mechanism.
But then the So it's never going to
Then it
remain
doesn't
as a
matter.
TB.
Correct.
So they made it,
Exactly.
there's no doubt.
Then-
But even post-operatively, the right eye will always remain the fixing eye. So
Correct.
you need not, worry about that.
Yes, it is
Go
very
back to the
important.
eyepieces.
Correct, correct.
The only thing was that in Vivo version, you can see the hypertropia is still pretty marked.
Right.
So that is why I think that probably the SR would be required. That's what I feel.
But the anti-elevation effect of the inflow-oblique will usually take care of that.
Otherwise, DVD unilaterally you operate, a mark of DVD of the other eye will come out. That's one.
Yeah.
The second point is in cases of asymmetric DVD with prominent fixating ability of one eye compared to the other eye. I operate only for the manifest DVD, the non-fixating. I leave it alone the other eye because that is anyway tends to be. Sometimes what I have done is I have used prisms. Give the prism correction to the manifest DVD. Okay? And this side will fixate and some amount of DVD will be there in the manifest DVD that prisms will take care of and you don't need surgery. That's one of the ways of managing DVD. Since this is a very marked and manifest DVD, I will operate on this DVD.
Right. So basically we gave just a minute.
One more. Sure.
I think, remember this child has a left head turn, head tilt. And the parents will not be happy if you just correct his esotropia and he remains with this head tilt. I think the very first thing you need to do is to explore the superior blight. You're assuming the superior blight, it may be redundant, in which case, as Dr. Sharma correctly said, you'll have to tuck it. But sometimes you'll find the superior blight is misplaced. Instead of being where it's supposed to be, it's on the other side of the superior rectus. It'll do very funny looking things and give you what looks like DVD, gives you all kinds of funny looking things because it's just in the wrong place. So the first thing you're obligated to do, I think, is to look for the superior blight. If you find an anomaly, which you probably will in this case, correct it. Be it tuck it, be it take it off its abnormal location and move it to where it should be, with or without a tuck. Whatever you need to do, you have to address the superior blight first. Then address the inferior blight, which probably needs to be recessed. And then I would agree with recessing the medial retinosis for esotropia. And hopefully you'll correct it all.
Sure, that should give you a right head tilt, not a left head tilt.
Yeah, but also you have other anomalies. You have the macula that's probably distorted. There are other possible explanations.
Okay. So I can take it forward. This is his practical position. Whenever a parent wants correction of this, this is what. And tilt is there, which is surprisingly a paradoxical one. It's like superior oblique is weak on the left side. We have the left head tilt. Probably we thought it could be because of point number one is because of the macular changes. And the most important point is because of DVD widening has. Because in DVD, they can have this weird tilt to right or even left. With regards to the patching, he is already having a very close compliance. Again, we gave it one more cycle of 3 months. Still, he did not improve, and this is his position just before the surgery. What we did was that there is a esotropia when we cover the right eye, it is reducing to almost 15 to 20% diameter. He had a DVD and the left hypertropia of 25% diameter. Approximately the inferior oblique takes care around 15% diameter. This is one of the thought process. And he had very lax superior oblique. So we had to do something for the superior oblique as per writing and that. And we had to tackle this DVD with inferior oblique protraction and hyperopsis. And this is what is the procedure what we have done. Medial rectus recession in the left side of 4.5 mm. Superior oblique tuck of 12 mm with inferior oblique anterior passage. These are the three procedures done only on the left side. Obviously, explaining that right DVD, we check really hard to see any kind of DVD in the right side. Usually, as Dr. Gopal said, we will do a bilateral DVD surgery. In this case, I was reluctant to do a right inferior oblique surgery for DVD. And this is his post-operative appearance, and this is his 9 days. You can even see the superior oblique when we explored the superior oblique, it was so lax that you could lift up the whole superior oblique like that.
Just give me the pointer last one. If you look at the left eye there.
Okay.
Look at the right eye. Where is it?
Anti-deviation.
Here, see here?
Yeah.
Do you think that the inferior oblique is gradually pulling the eye up?
Yeah, there are two things happening here. One is the anti-elevation caused by the left side, and obviously this is just 6 months now.
Yeah.
He might develop a DVD even in the right.
You will invariably develop a
Right.
I'm telling you.
Right.
See, that's already in 6 months there is a clue. I have seen where within 2 days the patient comes with the other eye. They said we have done whatever you taught us, sir, we have done, but now the other eye is there. And to my own consternation, I have one DVD with head posture like this. I immediately see the difference between superior oblique head posture and DVD head posture is superior oblique head tilt, I would say. Superior oblique head tilt is the opposite side and DVD head tilt is the same side. So if you are not careful, you will mistake it and then you will end up with problem. So I did not mistake, I did only the inferior oblique anteposition of the eye towards which you are splitting that, and the child really surprised me by tilting the head to the other side. The parents said, "Oh, we have done too much of operation, that's why it's tilting to the head to the other side." So you have to be very careful in explaining to the patient when you do unilateral DVD surgery that they will read on the other side. Okay? You've done a wonderful job.